Good morning. I'm Dr. Henry Ginsberg, and it is my pleasure to serve as the moderator for this webinar. Welcome and thank you for joining the American Heart Association for this educational webinar for healthcare professionals titled Lipoprotein A and Add Peripheral Artery Disease to the List of Targets. Disclaimer is shown here. The recommendations and opinions presented by our guests may not represent the official position of the American Heart Association. The AHA-ASA does not endorse any product or device. This activity is funded by an independent medical education grant from Kanaka Corporation. However, it's important to note that all program material was developed independently from the funder. We are totally independent members of the group that put this program together. And we are recording this webinar. This is the agenda slide. We'll have faculty disclosures shown to you. We'll show you the scientific advisory panel disclosures as well. Then we'll have the learning objectives, the presentations, a Q&A for all, and some housekeeping details, which I'll go over right now. First of all, some of our speakers, including Mark Banaka and Pia Kamstrup, are pre-recorded for technical reasons, and otherwise, Dr. Householder and myself are Householder Hughes and myself are live presentations. So here is our faculty. And by the way, continuing education credit information was already sent to all attendings who registered before the activity, and there'll be a follow-up email for you to claim your credits after the webinar is completed. The views and opinions are our own and reflect a synthesis of science. The content should not be considered, as I said before, an official policy of the American Heart Association. And if I'll have Pia and Mark and Sue turn on their cameras and unmute themselves, and we'll have each of us introduce ourselves. So I am the Irving Professor of Medicine and past director of the Irving Institute for Clinical and Translational Research, Vagelos College of Physicians and Surgeons. Dr. Kamstrup.
Hi, everybody. I'm so happy to be here. I'm Pia Kamstrup. I head the Department of Clinical Biochemistry at Copenhagen University Hospital, Herlev and Gentofte in Denmark. And I'm also a professor at the Department of Clinical Medicine at the University of Copenhagen. And I've worked with Lp(a) based on our large Copenhagen general population studies for many, many years. Thank you.
Mark Banaka, he's the Executive Director of CPC Clinical Research and Community Health, Professor of Medicine at the School of Medicine, University of Colorado. And Susan.
Yes, thanks, Dr. Ginsberg. I'm Susan Householder Hughes, and I'm a cardiovascular nurse practitioner. I've been practicing in cardiology for 48 years, and just 3 months ago, retired my clinical practice from the University of Michigan, where I served as a general cardiovascular nurse practitioner and had the opportunity to help create several interdisciplinary programs, one in coronary artery disease and the other for aortic pathologies. I continue to volunteer my services, and I also continue to teach. So it's a delight to be here with you today. Thank you.
Thank you. Thank you all. So this is a list of our overall disclosures, not simply related to this program, but disclosures of all types. And These are the disclosures of the scientific advisory panel. Susan and I are on that panel as well, serving double duty, but there are others as seen here, mostly without disclosures. So the learning objectives for today are to review currently available interventions that modify atherosclerotic cardiovascular disease, as well as PAD specific risk in individuals with elevated lipoprotein A. To review emerging therapies that may modify ASCVD risk and PAD risk, to evaluate ASCVD risk in individuals with elevated LPA, and to construct a treatment plan for individuals with both elevated LPA and PAD. One last reminder before we start, you can open up the Q&A feature on the Zoom bar, and you can at any time type in questions. There will be no oral questions asked, no verbal component on your side, but you can put questions in and we will get to as many as we can at the end of the session, and any we don't get to, we will answer later by other forms of communication. I'm now going to get us started. Lipoprotein A, add peripheral artery disease, PAD as we'll call it throughout, to the list of targets. So it's not known to many people who have recently learned about lipoprotein small a, LPA, but it was actually discovered and the data published in 1963 by someone named Kari Berg, who is a Norwegian immunologist, actually, who was studying lipoproteins. And at that point in time, LDL, HDL, and even intermediate density lipoprotein were identified. And he was looking for a new lipoprotein or an additional one. And using immunologic methodologies, he identified the lipoprotein that we now call LP(a) by finding an antibody that in the circulation to small a. So this is a timeline from a paper that Dr. Kamstrup published with several others, a review article of sort of the history of the science and the publication history and the interest in LPA. And as you can see, starting back in 1963 or so, when Dr. Berg identified LPA, there was not much going on for many years. There were little bumps, and there were certainly in Europe a few groups, particularly in Austria and Germany, that were interested in LPA. It was very difficult to isolate, very difficult, therefore, to study in other systems than looking at it in plasma. There were assays that were developed, some better than others, but there was a constant low level of interest. And then in the late 80s, the group in Genentech, led by Richard Lawn, cloned the gene for A, called with all capitals, LPA gene. And there was a great deal of interest sparked by that finding. You can see the rise in publications, and they leveled off, and then they remained moderately high and constant, but drifting downward until about certainly the 21st century, where larger epidemiologic studies and genetic epidemiologic studies using Mendelian randomization approaches began to raise interest again. And finally, as often we know happens in medical sciences, the pharmaceutical industry became interested, and then papers and funding rose rapidly. And still is, if you go and you just search in PubMed, you put in lipoprotein A, you will just find in the last 2 years, hundreds of papers. So there's a high level of interest. There are guidelines now that have added LPA, and things are moving forward rapidly, as we'll talk about. So I just started off with a couple of questions, certainly of interest to me, but should be of interest to all of you. What levels of LPA are considered high? And here we have one point that is very important for you to remember. You may have patients that go to different laboratories. And although the problem is been minimized recently, that is, we've had for a long time 2 sets of units, milligram per deciliter and nanomoles per liter. And most labs are now reporting in nanomoles per liter. It's a conversion factor they use, but at least you're getting a single unit from most laboratories. But in general, the milligram per deciliter level that you get from a laboratory will be 1/2 to maybe a little more than 1/2 lower than it is for nanomoles per liter. And that leads to the next line here, which says that the levels greater than 50 milligram per deciliter or 125 nanomoles per liter, that conversion factor being used here, are considered high. Now, it's a continuous risk factor. And we all know that we have continuous risk from LDL, we have continuous risk from other factors, blood pressure, but there are always cut points that are decided upon somewhat arbitrarily, somewhat based on epidemiologic data where risk really becomes elevated significantly and clinically important. And those are the numbers we're working with now. They may change in the future. And so again, it's a continuous risk factor, but those are the numbers above which you should really be concerned about your patients. The second is, there's been a lot in the literature over the last several years about LPA cholesterol, because it is a cholesterol carrying particle. Dr. Kamstrup will give you more information on that. And so there have been some assays developed, but in general, you don't need to know what the LPA cholesterol level is. You know what the LPA level is from the assays I just described. They're actually measuring the particles, and there's enough uncertainty as to how much cholesterol is in any one LPA particle that we're better off just looking at the LPA level. And the last is this issue of how does LDL compare to LPA? And again, Dr. Kamstrup will go through this, the differences and similarities between LPA and LDL, but very recent studies using genetic epidemiologic approaches suggest that one LPA particle is much more atherogenic than one LDL particle. We do, though, have many, many more LDL particles in the circulation compared to LPA. And so with that, I'd like now to turn the microphone and the screen over to Dr. Kamstrup's presentation. She will lead us through the biology and the epidemiology and the genetics of lipoprotein A.
Thank you to the organizers for the opportunity to contribute to this highly relevant educational session on lipoprotein A. Add peripheral artery disease to the list of targets. Today, I will briefly review Lp(a) particle structure and heritability, summarize the genetic epidemiologic evidence for Lp(a) as a causal risk factor for cardiovascular disease, and touch upon possible mechanisms of action. Lp(a) is synthesized by the liver and consists of a cholesterol-laden LDL-like particle covalently bound to the plasminogen-like glycoprotein apolipoprotein A. While plasminogen consists of 5 different crinkle-shaped protein structures, 1 through 5, and a protease domain, apolipoprotein A, coded for by the LPA gene, consists of several plasminogen-like crinkle 4 structures, type 1 through 10, 1 plasminogen-like crinkle 5 structure, and an inactive protease domain. Notably, the number of crinkle 4 type 2 structures vary between 2 and more than 40, and the LPA particle thus occurs as differently sized particles, with most individuals expressing 2 different isoforms, one from each LPA gene allele. Now, the rate of assembly and secretion of Lp(a) is mainly determined by the size of the LPA gene transcripts, with greater retention and thus less excretion of large apolipoprotein(a) isoforms compared to that of small apolipoprotein(a) isoforms. As demonstrated by the Lp(a) concentration distribution, here derived from a large sample of the Danish general population, Lp(a) levels vary widely between individuals. Importantly, Lp(a) levels are primarily genetically determined by variation in the LPA gene, as LPA particle size correlates inversely with plasma Lp(a) levels due to the aforementioned hepatic retention of large apolipoprotein(a) isoforms. Now, in addition to the LPA crinkle 4 type 2 copy number variation determining ApoA isoform size, a number of single nucleotide polymorphisms or SNPs in the LPA gene, some partly tracking the copy number variant, are also strongly associated with plasma Lp(a) levels. On the right, Lp(a) plasma levels are shown as a function of the number of crinkle 4 type 2 repeats in percentiles, and additionally stratified by carrier status for 2 common LPA SNPs. For each category of SNP carrier status, we see the inverse association of number of crinkle 4 type 2 repeats with plasma Lp(a) levels. Carriers of minor allele SNPs with low number of crinkle 4 type 2 repeats have the highest plasma Lp(a) levels. Now, while the genetic variants are not independent, all contribute information, and genotyping for just these 3 variants explains 45% of the total variation in plasma levels, clearly demonstrating that lipoprotein(a) plasma levels are very much genetically determined by variation in the LPA gene. While Lp(a) levels vary widely between individuals, the intra-individual variation is relatively modest, with levels being remarkably stable throughout life, as shown on the right, with age on the x-axis and Lp(a) levels in milligrams per deciliter or nanomoles per liter on the y-axis, but with the notable exception that levels increase somewhat in women at the time of menopause. Thus, high Lp(a) levels are relatively more frequent in women than in men after the age of 50. Furthermore, in individuals of European descent, the Lp(a) concentration distribution is highly skewed, with a long tail stretching out towards high and extremely high levels, and approximately 20% of the population having elevated levels. In other ethnicities, the concentration distribution may be less skewed, and median levels also vary with ethnicity. Now, in a global perspective, the highest median Lp(a) levels are thus found in Black individuals of African descent, while individuals of East Asian descent have the lowest levels. The difference results primarily from higher levels of Lp(a) being associated with medium-size apolipoprotein(a) alleles in people of African descent. Globally, an estimated more than 1 billion individuals have high Lp(a) levels and thus increased risk of ASCVD on this background. Now, we have used large Danish general population studies to examine the associations of high Lp(a) levels and corresponding LPA risk genotypes determining high levels with risk of morbidity and mortality. While the highest risk estimates have been found for myocardial infarction, calcific aortic valve stenosis, and as summarized on this slide, high Lp(a) levels additionally associate with increased risk also of incident heart failure, ischemic stroke, abdominal aortic aneurysm, and cardiovascular and total mortality. However, for these endpoints, Lp(a) levels typically have to be in the top 5 or top 1 percentile to translate into clinically relevant risk increases, as illustrated on this slide depicting adjusted hazard ratios for high and extremely high Lp(a) levels in the Copenhagen studies. For peripheral artery disease, we have recently demonstrated stepwise increases in risk of incident PAD with increasing Lp(a) levels, as seen on this slide, and with genetic evidence of causality with genotypes determining high levels also associating with increased risk. While the highest risk is found for Lp(a) levels in the top 5 or 1 percentile of the concentration distribution, that is, with levels exceeding 140 milligrams per deciliter or 300 nanomoles per liter, risk starts to increase already at levels above 30 milligrams per deciliter. In addition, we have also demonstrated increased risk of major adverse limb events in those with peripheral artery disease, and high Lp(a) levels. Finally, what is known at present about how Lp(a) causes ASCVD, including peripheral artery disease? While it is clear from genetic studies that high Lp(a) is a cause of polyvascular disease and also calcific aortic valve stenosis, the pathophysiology of the Lp(a) particle has not been fully elucidated. Thus, both pro-atherosclerotic, pro-inflammatory, and anti-fibrinolytic or pro-coagulant effects of the particle have been demonstrated as summarized on this slide. It is, however, unclear if high Lp(a) in humans directly contributes to thrombosis. Notably, though, the amount of plasma cholesterol carried by Lp(a) particles is usually much surpassed by that carried by LDL particles, indicating that particular properties of apolipoprotein likely contributes to the strong pathophysiology of the particle. Key takeaways from the present presentation include that lipoprotein(a) is a liver-derived LDL-like particle bound to an additional plasminogen-like protein apolipoprotein(a), that plasma levels are genetically determined, and that high levels represent a common, independent, and causal risk factor for ASCVD, calcific aortic valve stenosis, and mortality, and that Lp(a) levels above the 99th percentile predict threefold increases in risk of peripheral artery disease and major adverse limb events, and that mechanisms of action may include atherosclerosis, inflammation, and thrombosis, and that cardiovascular risk increases at Lp(a) levels above 30 milligrams per deciliter or 85 nanomoles per liter, and even more at levels above 50 milligrams per deciliter or 125 nanomoles per liter. Thank you for your attention.
Thank you very much, Pia. I would just make a point to the audience that that was pretty fast, because this is the second of two webinars, and if you want to get a much more detailed version of Dr. Kamstrup's presentation, you can go back on the AHA site and find the first presentation. Also, one other point to make is that even someone who has an LPA level of 300 nanomoles and an LDL cholesterol of 100 to 130, that would convert to about 2,000 nanomoles of LDL. So the marked risk of LPA is obvious even when it's only about 20%, at 25% at most, compared to people's LDL particle number. So it's a very, very potent risk factor. But it's incredible to see the progress that's been made in the last 25 to 30 years now. We'll now hear from Dr. Mark Banaka in his presentation on LPA and how it can inform clinical decision-making, especially for patients with peripheral artery disease.
Hi, my name is Mark Banaka. I am a vascular medicine specialist at the University of Colorado. Really an honor to be part of this session. So I'm going to build on this session and talk a little bit about how LPA informs our clinical decision-making in patients with peripheral artery disease. I want to begin with a case. This is a patient I recently saw. Historically, he had presented a ways back. His initial presentation was quite dramatic. He had the onset of acute right leg pain, came to the emergency room. He had no pulses. CT angiogram showed the acute thrombotic occlusion of his right femoral artery. It also involved the superficial femoral artery, profunda, and popliteal. He was treated with thrombolysis, and his limb was saved. He's a young man, 50 years old. We looked at his risk factors. LDL was 148, blood pressure 118/60, normal renal function, hemoglobin A1C of 4.8%. He's never smoked. His BMI is 25. He's very athletic. There's no family history of early athero, and you can see he was treated here with aspirin, clopidogrel, high-intensity statin, and he had a thrombophilia workup, as we often do with this type of acute thrombotic problem, and it was negative. So I'm talking about peripheral artery disease, and as you can see on this slide, it's just one of the manifestations or clinical manifestations of atherosclerosis, which of course is a systemic disease, but PAD patients have specific manifestations in limbs. Unfortunately, PAD is prevalent. You can see over 230 million individuals globally. More than 12 million in the United States are afflicted with peripheral artery disease, and many of them remain undiagnosed until they present like the patient I just described. Now, the prevalence of disease depends on who you are. The primary risk factors are age, diabetes, and smoking. And so if you look at the bottom of this slide, the partner study shows us that people that are over 70 or 50 to 69 with either a history of diabetes or smoking, within that group of patients, 1 in 3 has PAD. Again, the majority don't know that they have it. Why is it important to know? Well, you can see from these data from the 4AA trial that patients who have peripheral artery disease are extremely high risk for major adverse cardiovascular events. In fact, they're at higher risk than patients who've actually had an MI or had a stroke. You can see here, after adjustment for other risk factors, about an 80% increase in risk. But this risk is not the same for every patient with PAD, that there's a subset of patients who have what's called polyvascular disease. So symptomatic disease in the legs and the coronary distribution, for example, and those are in the red. Those are the highest risk patients. But even those patients with PAD alone, with no coronary disease or cerebrovascular disease, are at higher risk of MACE than patients who've had a prior MI or a prior stroke. But the thing that makes PAD patients different are really the progression of lower extremity symptoms and tissue loss at the end stage of disease. This is sort of the progression of disease, the journey for a patient with PAD. Most patients have mild functional impairment, or actually more than mild functional impairment, but they don't recognize that it's vascular disease. They attribute it to getting old or arthritis or other problems, and so they remain undiagnosed. When they progress and they develop more typical symptoms, they may come to attention. That may lead to investigations in terms of anatomy and revascularization if symptoms are severe. As the disease progresses, patients develop chronic limb-threatening ischemia, which can manifest in ulcers, tissue loss, and amputation. And one of the most feared manifestations, particularly in a patient who's had severe disease or revascularization, is acute limb ischemia. That's the ST elevation MI of the leg. And that's what this slide shows you, that with the patient that I presented to you had the equivalent of a heart attack of the leg. That is the acute thrombotic occlusion of a large artery threatening a large territory where time is muscle. If you don't reperfuse or open up that artery, then you have tissue loss. Time is muscle, and the mortality and rates of complications like amputation are extremely high. In fact, outcomes are worse for acute limb ischemia than what we observe for STEMI. So when we talk about risk in a patient with peripheral artery disease, yes, they are at high risk of heart attack and stroke, higher than patients typically that have coronary disease or cerebrovascular disease. And that's what I'm showing you in a registry on the left and a trial on the right. That's the red bars. But the dominant morbidity in the patient with PAD actually stems from their leg disease, and the risk of having an amputation or acute limb ischemia is high or higher than having a heart attack or stroke. And about 1 in 4 patients over 3 to 4 years will have severe progression of disease leading to either disabling symptoms or tissue loss that requires revascularization. So this is really the dominant morbidity. So what are the risk factors for PAD? I mentioned age, diabetes, smoking. There's also lipid risk. I talked about thrombosis risk, just like our patient had a thrombotic event, and diabetes risk. And so when we think about treatment, we talk about addressing all of these axes of risks, such as lipid lowering, diabetes treatment, antithrombotics, smoking cessation, and the foundation is lifestyle, healthy diet, and exercise. Well, what happened with our patient? You can see that 2 years after his presentation, despite his medical therapy, he had chest pain. He's an avid mountain biker. He had chest pain, didn't go away when he was resting. He went to the emergency room. He lives up in the mountains, so he's flown down here to Denver, where he was having a non-ST elevation myocardial infarction. And he had an angiogram. I'm showing a couple of pictures here, and he had severe multivessel coronary disease at 52 years old. We looked at his risk factors. Again, his LDL now was 63. He was on his lipid-lowering medication. He had an A1C of 4.8%, normal BMI, and he'd really made a lot of lifestyle changes to be even healthier. And he asked, after we had done his bypass surgery as he was recovering, he said, I have leg disease, I have heart disease, I'm 52, and I'm trying to do everything right. Like, what is happening to me? Why is this happening? And so, when we looked at his spectrum of disease here, you can see that he, from a lifestyle perspective, he was healthy, had normal BMI. His LDL had been elevated, but was now, not ideal. It should be less than 55, but it wasn't too bad. Doesn't have diabetes. His HSCRP was 1.22, so that wasn't elevated, never smoked, and had no thrombophilia. So I checked a lipoprotein little a in him, and lo and behold, it was quite elevated at 129 milligrams per deciliter. So what does that mean for this patient? Well, you've heard data, and I'll show you some data here, that LPA is very closely linked to PAD here from EPIC-NOFORC. You can see patients with an elevated lipoprotein little a have a higher incidence of developing peripheral artery disease. And you can see here that in another sample that patients who had levels above 30 milligrams per deciliter had higher risk of PAD, and particularly over 50 milligrams per deciliter. He's much higher than that. And when you look at the levels and the risk of amputation, those who had the highest tertile, over 50 milligrams per deciliter, had dramatically higher rates of amputation. So incident PAD, worse outcomes in those with PAD. And when we look anatomically, actually, we can see in these studies that when we look at anatomic classifications of disease like TASC and others, that patients with an elevated LPA are more likely to have severe anatomic disease. So more likely to develop leg disease, worse outcomes with leg disease, with high LPA, and then more severe anatomy. Here's a nice study that you can see, which describes some of the peripheral and aortic vents in patients with PAD. This was recently published in JACC in 2023. And you can see that people with an elevated LPA were at higher risk of developing PAD, AAA, and having major adverse limb events. And you can see that risk was amplified by smoking, which rings true for many of us that take care of these patients. We also know that LPA tends to be associated with a worse prognosis even after revascularization. So this is a large analysis that was done here. The stratification was at 30 milligrams per deciliter, so relatively low level. And you can see in patients who had an elevated LPA, they had much worse outcomes in terms of urgent revascularization or technical failure if they had a high lipoprotein A. Here's a similar study. This was also published in the Journal of the American College of Cardiology, showing that patients who have an elevated lipoprotein A have a higher risk of both MACE and adverse limb events. And if you look at the left side of the slide, actually, even at a relatively low cut point for LPA, the risk of major adverse limb events has an even stronger association with about a 4-fold risk. On the right side, you can see after endovascular treatment, that's what EVT means, patients with a high LPA had a much higher risk of recurrent adverse limb events than patients with a low lipoprotein A. So we know that these patients do worse even after appropriate revascularization. And this is at a relatively low cut point for LPA. As we think about what's sort of normal, many of the statements will say 50 milligrams per deciliter is a cut point for high risk, but we see in our PAD populations, even levels above 30 appear to be associated with worse outcomes. Well, what do we have for treatments? We don't have any LPA-directed therapies yet. There are several in development, which are very exciting, but we do have therapies. There are things that we can do. Here are data from the FOURIER trial, which was a trial evaluating the efficacy and safety of evolocumab, a PCSK9 inhibitor, in patients with atherosclerotic vascular disease. Evolocumab reduced major adverse cardiovascular events overall and in patients with PAD. But what was striking was this, and this is a somewhat unexpected finding, was a reduction in major adverse limb events. You can see a 42% relative risk reduction in major adverse limb events with consistent effects across the spectrum of acute limb ischemia, major amputation, and urgent revascularization. So evolocumab and monoclonal antibodies to PCSK9 appear to have efficacy. And in fact, when you look at the Odyssey trial, which investigated alirocumab, a different monoclonal antibody, they had exactly the same finding. And if you look at the two bottom curves here, strikingly similar pattern of efficacy for major adverse limb events for both of these monoclonal antibodies, as well as a greater benefit in absolute terms for MACE. So when you look at the benefit for these therapies in patients with PAD, there's a large benefit for MACE, but also for adverse limb events. What's driving that benefit? We haven't seen such striking results for statins, although those trials were older and maybe the endpoints weren't ascertained the same way, but it's truly impressive for the PCSK9 inhibitors. On the left, you can see that there was a clear relationship between the LDL lowering, or the LDL achieved at 1 month in the trial, and Fourier in major adverse limb events, a linear relationship that extended down to an LDL less than 10 milligrams per deciliter. But on the right side of the slide, you can also see data from Odyssey, which it appears that patients who had a higher LPA derived even greater benefit. So maybe not just LDL lowering. And what's fascinating is on this slide, you can see from Greg Schwartz's work that despite all of the quartiles of LPA in the trial, in the Odyssey trial, whether you were low or high, you got the same LDL reduction. But if you had a higher LPA, if you were in quartiles 3 or 4, you seem to derive an even greater benefit of alirocumab in this trial. And this suggests that perhaps Lp(a) is an effect modifier, or perhaps the modest reduction in LPA from the PCSK9 inhibitors has a synergistic effect. Regardless, these observed data certainly support the use of PCSK9 inhibitors in this population. So you may ask, what are the clinical implications? Why did I test? What can I do? Well, I think the most direct is that, well, we know why he had this. He has a high lipoprotein(a), and we know that treating that may be beneficial. We don't have direct treatment. We'll see what those trials show. But we do know from Fourier and Odyssey that lowering his LDL more was 60 milligrams per deciliter. So we could get a 60% reduction by adding one of these agents and get them well below 55 milligrams per deciliter, which are in the European guidelines. And we also know that patients with a high LPA appear to have greater limb reduction benefit. And there's a modest LPA lowering. So adding a PCSK9 would be a clear implication. You could even consider apheresis. Apheresis can be done. We do it at our center and actually offered for this patient because he had such a malignant phenotype. So there's a lipid action that you can do even before these novel agents are shown to be efficacious that you can do right now for your patients. But beyond that, there are other things that you can do. And that's why it's important to check. At the top, reinforce a healthy lifestyle, because this is a genetic factor. This is not elevated in everyone, and it underscores the need to be even more adherent to a healthy lifestyle. You can see on the right, family screening. So I did ask, and he has children that need to be tested. He's also very interested in participating in research studies and new trials, and I think that's important to engage our patients. Antithrombotic therapy. He was on aspirin monotherapy. Low-dose rivaroxaban is now approved by the FDA for the prevention of acute limb ischemia and for PAD, and it is now class 1 in the PAD guidelines. Now, some people worry about bleeding risk, but in a patient like this with an elevated LPA, which is prothrombotic, we would intensify his antithrombotic therapy, so add rivaroxaban. And then, although he's a non-smoker, further underscoring the critical nature of tobacco abstinence in this setting is important. So there's a lot to do here for our patients with PAD when we recognize they have an elevated Lp(a), and I encourage you to check. It's frequently elevated in this very high-risk population. Thank you for your attention.
Thanks so much, Mark. And his final slides really are a great introduction to the next speaker, and that is Susan.
Thank you, Dr. Ginsberg. Thank you very much. Developing a plan of care for individuals with PAD and elevated lipoprotein(a) is quite individualized, and thus it's important to obtain a comprehensive assessment to identify their specific risk factors so that we can aggressively help them to modify those risk factors until we actually have targeted therapies. As such, I think it's important that we have a knowledge of the current guidelines and protocols And moreover, a commitment to interdisciplinary team care, which I'd like to spend a little bit of time today talking about. I think these are essential for patient outcomes. And to enhance success in risk factor modification, assessment of a patient's social support system, their readiness to change behaviors, and their self-efficacy or their confidence to actually follow through on your recommendations is helpful. And to make all this work, obviously effective communication is key. Now, this slide simply illustrates the subsets of PAD, including asymptomatic, chronic symptomatic, chronic limb-threatening ischemia, and acute limb ischemia. And my point with this slide is just to make us all aware that patients will move in and out of different subsets through the course of their disease. And as such, changing their care plan accordingly is going to be a vital thing that we do. In June of this year, the American Heart Association and the American College of Cardiology, along with other organizations, published the Management of Lower Extremity PAD guidelines. The guidelines emphasize that individuals at an increased risk for PAD should have a thorough medical history, as well as review of symptoms to assess for exertional or rest leg symptoms, wounds, or other ischemic changes, as well as regular inspection of their feet and legs. Those at an increased risk include individuals 65 years and older, those between the ages of 50 and 60 with known risk factors, CKD, or family history of PAD, those less than 50 with diabetes and one other ASCVD risk factor, and individuals with known atherosclerotic disease and other vascular beds. And also, we should take into consideration the PAD risk amplifiers, which you can see on this slide, and including advanced age and frailty and depression and things that maybe we don't normally take into consideration in our day-to-day work. In addition, healthcare providers should look for evidence of health disparities such as race, ethnicity, geography, structural racism and implicit bias, as well as those social determinants of health, including lower education levels, poor health literacy, limited access to quality food and exercise, inadequate health insurance, and poor access to health care. When examining current national guidelines in relation to the measurement of Lp(a) in those with PAD, the 2022 European Atherosclerosis Society Consensus Statement recommends measuring this once in adults, interpreting the results in the context of absolute cardiovascular disease risk, and intensifying risk factor modification through lifestyle changes and medications. The 2021 Canadian Cardiovascular Society Guidelines for the Management of Dyslipidemia recommends measuring Lp(a) once in a person's lifetime and early intensive health behavior modification counseling, particularly if the level is greater than 50 milligrams per deciliter. The National Lipid Association now recommends measuring Lp(a) in all adults for risk assessment and recommends that those with elevated Lp(a) receive early, intensive risk factor management, including lifestyle modification and lipid-lowering therapy in high-risk individuals, primarily to reduce LDL levels. And you can see the defined classification levels on this slide. In preparing to develop a treatment plan and to recognize the importance of a multidisciplinary team, let's take a look at some of the guideline recommendations. I've purposefully, for time's sake, only included Class 1 and Class 2A recommendations. As you can see, there are many Class 1 medication recommendations for the various subsets of PAD. And those would be antiplatelets, anticoagulants, statin therapy, specific antihypertensive medications, and drugs to treat diabetes and claudication. Moreover, if you look at this slide, there's lots of evidence to suggest that we should be providing supervised exercise therapy or community-based exercise programs, engaging in smoking cessation activities, and then preventative foot self-care, explaining, educating to patients and their families, as well as inspecting the feet of these patients at every visit that we see them in. And let's not forget the importance of adequate diet and an appropriate diet. Now, having said that, this slide simply indicates all the different disciplines that we could choose to be part of our team. So you may decide to have a dietitian on the team, an exercise physiologist. You may have to engage in working with a fitness center staff. So there are a variety of different team members that I asked you to consider when developing a plan for patients with PAD. Most of us are most comfortable working with physicians, nurses, and pharmacists, but I assure you all the success of your program will only be enhanced the more disciplines that you can include. The concept of interdisciplinary collaboration is vital when developing a plan of care for patients. According to the World Health Organization, interdisciplinary collaboration occurs when two or more professions work together to achieve common goals, with the focus being to capitalize on each other's education, skill level, talents, and responsibilities. Research has demonstrated that improvement in access to care, patient outcomes, and prevention are all direct benefits of interdisciplinary care. So how do we facilitate this type of working relationship? I think it starts by being aware of our own professional shortcomings and to take the time to understand other disciplines and what they can do that is unique and what they can bring to the table that is different than your practice. Working together and participating in interdisciplinary education can help build mutual respect and trust. And it's important to create an environment so that each discipline feels free to verbalize their ideas, their concerns, and to ask questions without feeling threatened. And obviously, the use of guideline-based protocols can assist us all in staying focused on what's important and what management strategies are key. So really, it's important to maximize the skills and competencies of each discipline within their scope of practice and licensure. Interdisciplinary teams should consider the use of motivational interviewing to help patients elicit behavioral change. Motivational interviewing is a communication method that has been shown to enhance intrinsic motivation to change by exploring and resolving one's ambivalence related to that change. And this method takes into consideration the patient's beliefs, their desires, their values, and their concerns. It is frequently used along with other methods to motivate behavior change. There are 4 guiding principles to motivational interviewing: conveying empathy, simply being non-judgmental, and asking the patient to tell their story and actively listening to their perspectives; evolving discrepancy, helping the patient to identify where they are in the disease process and where they need to be, and help them to develop goals that meet within their own value system. Rolling with resistance can be the most difficult for us healthcare providers, but we have to allow the patients to explore why they're ambivalent to change in order for us to help them. And then enhancing self-confidence, self-efficacy, praising them, reassuring them that they're able to meet goals and developing goals that are attainable. A key foundation of motivational interviewing is respectful communication, which includes the use of open-ended questions, affirmation, reflective listening, and summary statements. Let's take a look at what those kind of statements might look like in a smoking cessation exchange. So for instance, if you wanted to start an encounter, you might ask a patient, "I understand you are here to discuss smoking cessation. Can you share with me what's worked for you in the past? What hasn't worked?" An affirmation statement may sound like this: "You know, Mary, you've worked very hard to lower your cigarette consumption from 1 pack to a half a pack per day over the last month. Congratulations. That was hard work. Keep it going." A reflection statement might look like this: "You've tried to stop smoking in the past and you've been unsuccessful. You're currently afraid to try because you might fail, again, because of your values to lose weight, and because right now you exposed to me that you have a high stress level." Summarizing statement might be something like this: "To summarize, Mary, what you just said, you don't feel capable of being able to completely stop smoking because you desire to lose weight and you feel stressed about this. This takes practice, trust me. I've tried it. I used it in my clinical practice. It's very effective, but the only way to be good at it is to practice. Shared decision-making is another important concept to consider when developing care plans and is a technique recommended in most guideline documents today. It is a communication process whereby healthcare providers and patients work together to determine the best option for management of their health problems. It places an extremely high priority on patient preferences, patient values, what their goals are, not what ours are. And it's important to allow the patient to participate in as much of or as little of the decision-making process as they desire. Please take into consideration their health literacy as well during all communications. Shared decision-making requires that as healthcare providers, we communicate the problem, outline the treatment options, provide the risks and the benefits of those options, and then step back and allow the patients and ask them to make a determination of what is best for them. It may be different than what we believe is best for them, but this is the true essence and spirit of shared decision-making. And I want to encourage all of you, there are many resources online from different organizations that can help you build a practice around shared decision-making. So in conclusion, I'll leave you with some practical tips for implementation of an interdisciplinary team. First, I think organizational support is key, with committed administrators for financial support, space, equipment, allowance of time, and other logistic type of concerns. A physician leader needs to be in place, as well as a program coordinator. Most programs have nurses as program coordinators, but they could be any discipline that you see fit. These individuals will set the tone for the vision and the goals of the team, as well as the program. Then identify your team members that are important for program success and assure that their respective responsibilities are clearly outlined. Have regular team meetings, have regular interdisciplinary education. Practice together, sit side by side, share your strengths, talk about what makes your discipline so unique. This can truly build trust and mutual respect, and allow each team member to practice at their level of licensure and scope of practice. So important. I assure you all, interdisciplinary team work can be fun. We can learn a lot from each other, and it truly can benefit our patients. We can certainly learn a lot from competitive sports teams. Most of us love watching football these days. And Vince Lombardi, considered to be among the greatest football coaches ever, leading the Green Bay Packers to 5 NFL victories in just 7 years, said, and I quote, "The challenge of every team is to build a feeling of oneness, of dependence on one another, because the question is usually not how well each person performs, but how well they work together." And you all know you can have a great quarterback on the field, but without the other team members, you'll lose the game. Thank you so much, and I'll turn it over to Dr. Ginsberg.
Thank you very much, Susan. We're, as usual, very tight for time, and that's okay because my topic is new emerging therapies, and it's very simple. We don't have a therapy yet proven to lower LPA levels. We have therapies that amazingly lower all lower LPA, and I'm just going to briefly show you the data for that one slide piece. So the first is a drug which is an antisense oligonucleotide, pelacarsen, and it is now near the end of its phase 3 CVOT outcome. This is a phase 2B trial, a dose response trial, and if you just look at the bottom lines, you can see that this drug was given every 2 to 4 weeks with remarkable reductions in LPA levels. These are percent changes. The next drug is olpasiran, which is one of the silencing RNA group of drugs that are in slightly different from an antisense oligonucleotide in the mode of action. They all reduce the synthesis of the little a protein. And in this phase 2 trial, you can see that over 9 months, there was a dramatic, remarkable reduction at all the doses with olpasiran. The next drug is lipodicerin, another of the silencing RNAs. This is a phase 1 dose finding study, and this single ascending dose, and again, quite dramatic, remarkable reductions. This is zerlasiran, phase 1 trial. The results, it's very repetitively incredibly good, these drugs and what they can do. And the last of these are muvalaplin, which is not an ASO, not an siRNA, but is an oral agent that breaks the bond between ApoA and ApoB, disrupts it, thereby reducing the amount of LPA particles in the circulation. Not clear if that happens in the liver or in the circulation, but not quite as dramatic as the others, but could be quite a boon when we get to possibly primary prevention patients or patients at the lower end who don't need 90% reductions to get into a very healthy range. And so I will just finish with one point, and that is measurement of LPA is abysmally low. If you look at the AHA guidelines, which give you a list of reasons you should get an LPA in a patient, and then you put those into large electronic health records, 2 to 3% of those subjects will have gotten an LPA. We need to do better than that. It's elevated dramatically in at least 10% of the population. Getting it measured in your patients with increased risk for atherosclerotic cardiovascular disease is absolutely necessary. And so thank you all for participating out there in the real world, and for all my colleagues here providing the presentations. And we have maybe a minute or two left to take some questions.
There was one question inserted about Repatha, if that is able to help lower Lp(a), and then we should go ahead and close on that note.
So the PCSK9 inhibitors, whether it's Repatha or Praluent, they not only lower LDL cholesterol 50 to 60%, but they lower LPA between 15 and 30%. And that ought to be based on the epidemiologic data, the genetic epidemiology as well, that should give you a modest reduction. And I think if your level is 300 and you get a 30% reduction, that would be a very good outcome with a significant reduction in risk. So I think that's the answer to that question. I wish we could get the drugs for everyone who just had a high LPA, but that is difficult. And with that, again, I want to thank everybody participating. We'll close, and hopefully you'll all go to the AHA website and look for the first webinar if you missed it, and look for other resources related to all things cardiac. Thank you very much.